نبلش بالصلاة. أبانا الذي في السماوات ليتقدس اسمك، ليأتي ملكوتك، لتكن مشيئتك كما في السماء كذلك على الأرض. خبزنا الجوهري أعطنا اليوم، واترك لنا ما علينا كما نترك نحن لمن لنا عليه، ولا تدخلنا في تجربة لكن نجي من الشرير. آمين. أهلا وسهلا، تفضل. أهلا وسهلا فيكم. ما عندي شو أقوله غير إنه رحب فيكم، بكون يا أهلا وسهلا فيكم. شغال منيحة، أحسن. وتفضلي دكتورة.
Good evening, everybody. My name is Mona Rassi, and I'm so happy and excited to see you all here tonight, especially that this is the first event organized by the Health and Wellness Ministry of St. Mary's Church. This ministry was started with the purpose of serving you, serving the parishioners and the community through educational sessions like tonight, and providing resources and advice related to your health, as well as to advocate on your behalf as needed. We are a group of healthcare providers, and we are still in the process of organizing and planning. So I'm going to take this opportunity to ask any one of you, or if you know anyone who is in the healthcare field, to please join us. You can contact me and join us. We really need your help. And now I'm pleased to introduce our speaker for tonight, Dr. Maya Deeb. Dr. Maya, she's an active member of the Ministry of the Health and Wellness Ministry, and of course, she's a member of our church. Dr. Maya, she's a resident doctor in internal medicine at University of Toronto. She grew up in Abu Dhabi and has been in Toronto for the past 10 years, where she completed her undergraduate medical degree. She will be staying in Toronto to pursue further training in gastroenterology next year. We are so proud of Maya's accomplishments, and we thank her for leading this interesting discussion tonight, which is titled, Are You in Control? And please note that this discussion, this session, is going to be recorded, and it will be shared with everybody later on. So please join me in welcoming Dr. Maya.
So you can all call me Maya. Thank you, Auntie, for that nice introduction. For those of you who don't know me, I want to start by saying this is a talk about addiction. I'm not an expert in addiction, but I'll tell you a little bit about what I do so that you know about my contact with addiction and my exposure to it and where all of this is coming from. I'm a resident in internal medicine. I'm in my last year of internal medicine and in general internal medicine. So for those of you who aren't familiar with the term, طب داخلية. So this is the general field you go into before you go into the subspecialties of cardiology, respirology, and so on and so forth. The bulk of what we do is take care of patients who are sick enough to need to stay in the hospital. So this is the majority of what I do. And in that capacity, I come across a lot of patients who have issues with addiction. And so addiction is something that I see on my day-to-day basis, whether it's looking after patients who are in alcohol withdrawal or have alcohol-related liver failure, or if it's patients who have smoking-related cancer. And so it's from that exposure to how much addiction affects those people and the families involved and all of their loved ones that I wanted for this to kind of start a discussion about the choices we make, the choices our loved ones make, and particularly within our church community. This is a talk I actually gave 2 years ago to the teens in my church in Abu Dhabi. So this is a talk I gave in 2019 to grades 7 to 10 around addiction. And so I organized it such that it's part surface level science and part social and Christian discussion, okay? And so I think all of you by now have a piece of paper and a pen or can share pens. If you don't, then Natalie at the back, Natalie in the front are ready to pass those around. The reason I pass those around is so that you can write questions anonymously. All of the papers are going to be collected, whether you wrote a question or not. And we will try to answer as many of those as possible by the end. If I can't answer them, I will look for the answer. And Abuna will be around to help as well. Okay. So I will begin the talk with a very surface level discussion of the reward system. We all have a reward system that is built in our brains. And this is again an oversimplification. It involves a lot of different chemicals. The most prominent of these chemicals is dopamine. Dopamine is the chemical that makes us feel happy, the chemical that gives us joy, that makes us feel feelings of motivation and all of the good things that come along with that. And ever since we are young, we use this reward system to learn about our environment. So if you have a little child who is scared of like an animal and sees mom, going to mom makes him feel good, makes him release dopamine. And so the child learns that I should seek mom when there is danger. And so this is how we learn about our environment in a very simplistic way, if you will. And we manipulate the system. So when we are teaching little kids, we use the system to teach them good things. So if you're teaching a child how to share, when they share, you will reward them with a chocolate bar, and then they feel good, they release dopamine, and so they learn that sharing is something that will make me feel good, and they repeat this behavior. But just like we manipulate this system, so can drugs. Okay? The thing is with drugs, is when you take a drug, and I'm not talking about like the hardcore heroin, I'm talking about anything that will make you feel good, whether it's alcohol, whether it's marijuana, whether it's cigarette smoking, anything that we think of as benign, as completely common in our society. Anything that makes you feel good is going to make you release dopamine. But the thing is with all of these drugs is that they work on this reward system in a way to make you release so much dopamine that your brain is swimming in dopamine and it's not used to this much dopamine. And so your brain's like, well, this is too much dopamine. And so your brain, in a way to protect itself, will reduce the number of receptors that react to dopamine. Okay? So now you have less receptors to dopamine because you're taking this drug and your brain is used to like a crazy amount of dopamine. And you have less dopamine receptors. The problem with that is that now every time there is a normal reaction that is supposed to make you feel happy, you have fewer dopamine receptors and you're not going to respond to it the same way you would have if your brain had not seen this much dopamine. Is this making sense? Okay. And so this is essentially the definition of addiction, right? Like something else has hijacked this reward system and altered the way your brain is responding to things that it would have responded to so normally before, okay? And so you have essentially given up control of your reward system to whatever it is that has manipulated all of these receptors in your brain. Again, this is super oversimplified, but essentially, at a basic level, this is what's happening. But of course, it's not just drugs that do this. Like drugs are a very easy example because I can tell you exactly what happens chemically in the brain with the receptors. But we can divide addiction to both drug-related addiction and behavioral addiction. We're all very, very familiar, I think, with addiction to porn, addiction to social media. I think we've all been there at some level with respect to social media. It's very well described. I've personally seen patients who are addicted to shopping in a pathologic way, addicted to food, addicted to their body image. And so there are so many behaviors that play on this system as well and manipulate it so that whatever it is that your brain is so fixated on has hijacked the reward system and taken it off rails. For the sake of this talk, for the simplicity of the discussion, I'm going to focus on drug addiction. So like, why do people use drugs to begin with? It sounds so unattractive, and I've painted this disastrous picture of it. There's many reasons. I think some of us feel empty, whether it's intellectually or emotionally or physically, and this is kind of like a way for us to fill in that void. Low self-esteem is a huge one, I think. So I mean, my exposure to psychiatry is limited. I mean, addiction medicine in itself is a year or two specialization. And so for me, I would have done like 8 weeks of psychiatry, 6 of adult and 2 of child psychiatry when I was in medical school. But you could see how much peer pressure changes the things we do. I mean, peer pressure affects me and I'm 27. So, so much more when we're younger. And then some people go to it for relaxation because it's a way to put your mind off of things. And I think this is an easy one for us to understand. And then I can imagine if I was a teen sitting here, I would be like, but you're not talking about me and I only want to live once and I'm just going to try this and I'm just going to explore. And why can't I just blend in and we're at a party and everyone's trying this thing, so I'm not harming anyone and I know what I'm doing and I'm in control and I'm just going to try it. And these are not like, these are totally common thoughts, I think. And so how fast does something go from just trying it to an addiction? And the answer is, it depends. It depends on a lot of things. It depends on the drug itself. The higher the high, and the more reinforcing, and the more that reward system is like on fire, the more addictive the drug. Like heroin is extremely addictive because the high is so high. It depends on stressors in your life. The people who tend to become addicted to substances are people who have background stressors. And this doesn't necessarily I can't waste time like this. Thank you. That's okay. Is this better? Okay. Yeah, so I was saying having goals is kind of a protector because it's such a deterrent. You know, I can't spend time on this kind of drug or spending time finding this kind of drug because I need to get this degree. So that's very protective. Genetics and family addiction. So they kind of work hand in hand. Oftentimes you'll see people with alcohol addiction and they'll tell you, oh, my dad, oh, my aunt, or whatever, also struggled with alcohol or had alcohol-related liver disease or whatever. And not all of this is just exposure, just because someone in your family is doing this and you think it's normal, so you do it too, but there is like a genetic component to it, a real genetic predisposition. And then finally, and this is why this was so important, is that the younger you start, the faster the addiction progresses and the more difficult it is to quit. And this is why it's so important to start this discussion and start this thought process at a young age. So the drug that I'm going to focus on is nicotine. I think because it's so common, I think especially in the Middle Eastern community. I don't think any of us don't know someone within the vicinity who smokes cigarettes. And I think we think of it as a benign drug so often that I'm going to make it the focus of this talk, partly because it's a good example for the sake of the discussion, and partly because a lot of us think of it as benign and social, and I just smoke socially. I have a lot of patients who tell me, oh, I just smoke socially. Like if we go out to a party, like I'll have a cigar or like I'll have shisha or whatever. And it's so normalized in our culture that that's the reason I chose to speak about this today. So we call nicotine the chameleon drug. We call it the chameleon drug because if you're super tense, it's going to make you relax. And if you are super tired, it's going to stimulate you. So for a lot of people, their work-life stressors is such a driver to continue smoking cigarettes. It acts very rapidly, and the more rapidly a drug acts, the faster it produces its effect, the more reinforcing of that reward system it will be, and the more addictive it will be. And actually, nicotine is the most difficult drug to quit. So people think, oh, like if you take fentanyl, that's the most difficult drug to quit and you're stuck. No, actually, we know that nicotine is the most difficult drug to quit. And so when a patient comes in and they tell me, oh, I quit a year ago, it's like, huge congratulations. Like, this is a huge step. You made such a big move, because it really, really is difficult to quit. But obviously nobody takes the nicotine on its own. It's obviously mixed with something else. Usually it's in the form of shisha or in the form of a cigarette. And the new but not so new format of this is a nicotine inhaler. Does anyone here not know someone who uses a vaporizer or e-cigarette or nicotine inhaler? Does not know someone? Yeah, so someone around us uses a nicotine inhaler. And I think they've become extremely popular, I want to say over the past 5 years, because they come in flavors. What a disaster. And I'm not going to go into like why smoking is bad for your health. I think we all know that. I'm not going to dive into this. You could name any organ system for me, and I can tell you how smoking will mess it up. I can tell you how smoking will mess up how you heal your wounds. And there are surgeons who will refuse to operate on you if you don't quit smoking. So we're not going to go into that. But I want to rewind to how smoking was advertised like in the 40s and the 50s. And I want you to look at these ads, not just because they're entertaining, but because I want you to think about how science changes and what we think about things changes, and the evidence we gather about how good or bad something changes. So this is, let's say, over 60 years ago. This is how we used to advertise smoking. More doctors smoke Camels than any other cigarettes. But this is my favorite one, because look what it says. It says it gives immediate relief in cases of asthma, cough, bronchitis, hay fever, influenza, and shortness of breath, which is like, you don't need to be a doctor to know it makes it worse. But this is how we used to think about smoking. And the reason I bring this up is that I think we may be doing this again, because this is how inhalers are now advertised in a very, very similar way. Let's call them e-cigarettes moving forward. And so you see that they're super glamorous and trendy, and all of the people we admire and people we see in TV all smoke e-cigarettes, and it's really trendy. And it's super sexy because you scroll through your Instagram and like, I challenge you not to see an image of someone, a celebrity or something, or a friend of a friend who is using an e-cigarette. And there's a ton of memes, and it's really funny. And honestly, like going through this, like even I was laughing, even though I don't even use an e-cigarette, and I was laughing at all of these things. And so once it becomes so ingrained in our culture and in the kind of things we send to each other and enjoy with each other, I think that normalizes it so much, and it becomes such and not a big deal. And most of us use e-cigarettes anyway, and so what's the big deal? But it is actually a disaster, because now the FDA, so this is the Health Canada of the US, I'm sure you all know, is finding that a lot of children, and there's tons of surveys showing that teens are now so hooked onto e-cigarettes, so much more than if you look at the surveys before, looking at how many teens were starting to smoke regular cigarettes, because now it's seen as a clean form of smoking because it doesn't come with the tar and what is perceived to be the worst part of a cigarette, and because they're flavored. And so we should know something about nicotine in itself. So the e-cigarettes have nicotine, and we should all know a few things about nicotine. Apart from the tar, apart from the rest of it that comes with the cigarette, apart from whatever comes with the shisha, nicotine itself is addictive and is toxic. And if you're under 25, it can harm your brain development. And this is why we tell pregnant ladies not to smoke cigarettes. Once you stop taking the inhaler, within 1 hour, you will start feeling the cravings for more nicotine. And those cravings can last for weeks to months. And this is why quitting nicotine is extremely difficult. And so when I tell a patient you should quit and they're ready to quit, I tell them you're going to fail. And usually most people take 4 to 11 times to actually quit cigarette smoking. It's not easy. And so in terms of e-cigarettes, things we need to know, most e-cigarettes actually have nicotine. And the amount, and you know, a lot of people will say, oh, but the e-cigarettes give me so much less nicotine than a regular cigarette, so it's not as big a deal. And you know, it's really, really difficult. And you look at the container, and so all of this is, if you want to, I'm happy to share the PDF with any of you. So if you go to this is the Canadian Pediatric Society document. The container for any of these vaporizers, any of these e-cigarettes, will say whatever, this has X% of nicotine. But the thing is, the way these inhalers work is you've got a liquid, and then the little machine has a vaporizer that will vaporize the liquid, and the process of vaporization itself is going to sometimes increase the percentage of nicotine in whatever you're inhaling. And so it's really, really difficult to actually estimate how much nicotine you're getting from those things. And so when it's advertised like there's less nicotine, that's less nicotine in the liquid, not in the vapor that you are inhaling. And so there's been studies to show that e-cigarettes can cause the same heart and lung problem as regular cigarettes. We know they contain stuff that can cause cancer, and we know they contain stuff that we don't know what it does yet. There's one thing that a lot of people who use e-cigarettes will say, but actually it helps a lot of people quit smoking. Have any of you heard that? Like our friends who smoke cigarettes and are like, oh, I stopped real cigarettes and now I'm taking it. So this piece I actually had to add because I had to add it this morning when I was looking at the talk again, because there is a new Cochrane review. So what a Cochrane review is, this is a kind of review in medicine where some team came together and looked at all of the studies that look at a specific question. So the question here was, do e-cigarettes help people quit smoking better than other things like nicotine replacement therapy? So there's like gums and patches you may have heard of that people use to quit smoking cigarettes. And so they looked at a small number of studies. A small number of studies in medicine is 61 studies. So this study, this Cochrane review here, looked at 61 studies, and they found that maybe it helps people quit cigarettes, quit the real cigarettes, more than the other things. But there weren't studies that, for example, compared the inhalers with drugs. So the first thing, if someone comes into my office and says, I want to quit smoking, I would say you should do it with the help of a drug called Champix. Have people heard of Champix before? Varenicline. I have friends who have been on it and quit smoking. But usually we recommend a drug aid. There weren't any studies that actually compared the inhalers with drugs. So this is an incomplete study. Like, yes, they may be helpful for people who used to smoke before, but it's an incomplete study. And really the evidence is super, super new around whether we should use e-cigarettes to quit real cigarettes. And I hope that for the teens in the room, this isn't you guys. We're not going from real cigarettes to e-cigarettes. Anyway, in some people, they do actually cause them to smoke real cigarettes, which is even worse. And as with any drug, they do have social and psychological effects. But that's the science part of the conversation. So I've been talking science, surface level science, I want to say for now. as a church, and this is where we are right now, why do we care about this? And we care because it's very well worded by St. Paul here, and I'm going to read the English portion of this. All things are lawful, but not all things are helpful. All things are lawful, but not all things build up. All things are lawful for me, but I will not be brought under the power of any. And this is why I titled the talk, Are You in Control? Reason number one we should care about this is that drug addiction does destroy God's temple. Okay, so we are God's holy temple. Here is the reference verse. Or do you not know that your body is the temple of the Holy Spirit who is in you, whom you have from God, and you are not your own? For you were bought at a price. Therefore glorify God in your body and in your spirit, which are God's. The number two reason is that drug addiction is a merciless master. It truly, truly is. Like if you see these people come into the hospital, it's very hard to hate them because you can see how much it's a disease. It's truly, truly a disease when it becomes beyond your control. No one can serve two masters, for either he will hate the one and love the other, or else he will be loyal to the one and despise the other. You cannot serve God and mammon. Reason number three is that it's the beginning of other sins. So drug addiction drives us to a series of sins. So this is from 1 Peter. Be sober, be vigilant, because your adversary, the devil, walks about like a roaring lion, seeking whom he may devour. Reason number four is a bit of a repeat because it's kind of like the merciless master. Drug addiction leads to the feeling of defeat and loss because you're not in control anymore. Something else is. And so this is the point at which you truly, truly need help. And it hinders your repentance because you feel stuck. You feel completely stuck and you feel like you have no way out of any of this. And so in terms of thinking of solutions to the problem, St. Paul also mentions 4 parameters whenever we are trying to make a choice. We should think of 4 things. Does it control me? Is it beneficial? Is it suitable as a Christian? And does it offend others? So whenever we're choosing to do something, yes, I know those decisions may be made at a party, but those are things we should think about in advance so that we don't have to think about these things in the moment. And then be vigilant. And I want to go back to the slide where the roaring lion one, because I really like that verse. Be sober, be vigilant, because your adversary, the devil, walks about like a roaring lion, seeking whom he may devour. And so in the solution, it's really important for us to be vigilant, to think, is there something I depend on? Is there something that distracts me from God? Whether it's vaping, whether it's social media, whether it's partying. And this doesn't have to be grand. This can mean going through the list that you follow on Instagram. I try to do this regularly. I go through the list of people I follow on Instagram, like, does this person I follow, every time I see their story, I'm swearing at them, I'm just going to unfollow them. Is there anything that distracts me from God? And this cleanup doesn't have to be a grand gesture. It can be very simple. It can be going through your social media account. And then what are the circumstances that get me in there? Is there a specific group of people? Is there a time of day? Is there a specific mood I'm in where this happens? Then just avoid those things. And so it's really important, I think, especially when we're younger, to say no. It's difficult. People may hate you for it. It's something that takes practice. It's not like you're going to walk in and you're going to know exactly what to say to your friends when they offer you something you're not convinced of. Avoid the circumstances, the people who lead to this behavior. And then this is harder, I think, but try to suggest something else. Maybe you can make a difference, maybe not. This is harder. And then keep busy, because if you remember that slide where I was talking about having goals, Having goals and having something to work towards is really, really protective from making poor decisions. And then finally, seeking help. I think sometimes it gets out of hand, and it's important to know when you need help. I think the smartest people are the people who know when to look for help. True help comes from Jesus Christ. So of course, help is in the scriptures. Of course, help is in the church. But also your family, also your friends. You have to recognize, like, in the end, this is your life that you're losing with all of this. And so it's important to make that step and look for help and talk to somebody about it. And most importantly, it's important to have hope. So this is from Philippians. But one thing I do, forgetting those things which are behind and reaching forward to those things which are ahead. This is a favorite icon of mine. Do you know the name of this icon? Yeah, so this is the icon of the prodigal son. I thought it was very relevant here. It's a favorite. But that's really all I had to say. I'm happy to take any questions. And you can write them down on a piece of paper, and we'll collect them in 5 minutes, and we'll start parsing through them. They will be entirely anonymous, but I'm happy to take any questions. These are the resources. I'm going to make a few plugs before people start writing questions. This is where I got my material from, but an app, you should all download this app that I listen to very often. It's an Orthodox app. It's entirely in English. It's organized by the Coptic Church. It's called Upper Room Media. Very great app. Lots of good social talks, theologic talks. They range from 5 minutes long to an hour and a half long. I listen to these on my drive. I listen to these on my walks. And so a lot of the material and the references I got from talks from Upper Room Media. Coptic Orthodox Answers is also a good one. I don't know if any of you have heard of it. We have essentially the same doctrine, and so this is all in English, but again, they have very well organized website that goes through a lot of theologic questions. And then the last plug is for our health and wellness ministry. If you're interested in healthcare or are in healthcare, please join us. If you're interested in medical school, please reach out to me. I'm happy to help anybody through the path. I did do both undergrad and med school here, and I think it's important for more people from the church to be within medicine because of this precisely. And so if you have any questions about that, please do reach out. You can find me on Facebook, Maya Deeb, or you can email me. I'm happy to give you my email or phone number if you reach out. That's it. Take questions. So while some questions trickle in, I'll start with the first one I have here. Apologies in advance to whoever asked this, because I can't answer this in like under 5 minutes very well. So the question says, what is the difference between smoking cigarettes and smoking marijuana? And what is the effect on the brain? Giant question, because I can ramble forever. But in terms of smoking cigarettes and smoking marijuana, we talked about smoking cigarettes a bit, so I'm not going to repeat that. Marijuana is a topic in itself. I'm happy to prepare a talk about marijuana. Is this something people are interested in? Talk about marijuana? Okay, because this is important for like our team to prepare. Oh, 100%. Oh, for sure. So I think we can prepare a talk about marijuana, and just in brief for whoever asked the question, in the interim, marijuana is a hard topic because marijuana comes in so many different forms, okay? You can have a distilled form of marijuana that's THC, so that's used medicinally, does not have the high effect. I'm gonna park that because I don't think any of us are talking about that. And then there's marijuana that comes in the form of smoking, so rolled in a joint, and you can think of it in grams. That's closer to smoking cigarettes because there's more stuff rolled up in the joint than the THC. And then there's bongs, and then there's edibles, and there's so many different formats that you can take the marijuana in. Marijuana is tough because we don't have that much data about marijuana. Like, we don't have the 70-year accumulated evidence that we have about cigarette smoking. We do know it affects brain function. We do know it can cause psychiatric disease, but it's not like a dose-related effect. It's not like alcohol, where you drink X amount and then you shouldn't drive because you're impaired. And if you stop taking the alcohol, the withdrawal looks like this. It's not very well described because each person responds to the marijuana differently, and it depends on how much you use and how much becomes your baseline amount in your blood. I'm already rambling because marijuana is such a huge topic. Like, I think it deserves its own talk. Is that fair? Like, is it okay if we park marijuana and make that its own talk? Yeah. Are you talking about vaping or marijuana? Okay. Yeah. Well, not a lot of legal things aren't great things. So if we're going to go down that argument, like, we can start talking about a lot of things. Well, so are cigarettes, so are smoking cigarettes, that's also legal. So is alcohol, that's also legal. There's a lot of legal things that are not good for us, and we can go back and reference St. Paul's verse, but it's hard because everyone around them is using it. It's really hard. The doctor argument, there's like two things that we have some evidence to use marijuana for. Two things. One is cancer-related nausea. So these are the people who are getting chemotherapy and aren't responding to any of the other drugs. Then we give them THC. THC is not going to make them high. Okay, so we're not talking about the marijuana you get from the stores or the street. The second thing is neuropathic pain. Neuropathic pain is pain that is burning, tingling, because there's nerve damage. These are the two things in medicine that we have some evidence for to use THC. So the argument that there's medicinal marijuana is not a very good one. These are the things we have evidence for. There are doctors who will prescribe it for other things. I can list a whole bunch of things that doctors will prescribe it for, but these are doctors who are prescribing it off guidelines, who, if something happened to this patient and they were to go to court, they probably can't defend themselves because there's no evidence for it. So when you bring up the doctor argument, there's really two things that we sort of have evidence for medicinal marijuana. So that's not a very good argument. So that's one. Its legal part is one, because smoking cigarettes is legal, alcohol is legal. There's a whole bunch of things that are terrible and legal. So that's out. And then the other argument is, it doesn't affect your brain. No, it does affect your brain. And if you want me to gather a bunch of resources around how marijuana affects your brain, I will gladly do that. I mean, I don't even have to gather it, to be honest. If you go to camh.ca, there are already available documents about what marijuana does to your brain, particularly below the age of 25. But I am sensing that we need a marijuana talk, right? Okay. Yeah. 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 I agree. I think this is an important topic, and so it should probably be our next one. Yeah. I think that. Oh, these are great questions. Okay, this one. What will you do after your residency? So this is my 3rd year of internal medicine residency. When you do internal medicine here, you do 3 years of internal medicine, and then you either stay in internal medicine for 1 or 2 more years, or you branch into a subspecialty. I'm going to be doing gastroenterology, so that's stomach, liver, colon. I want to be a liver doctor, so stay tuned. How can I help my dad, who has been addicted to nicotine, regular cigarettes, for 35 years? This is really tough. This is a really tough one. So when you want to help someone quit cigarettes, it depends on where that person is coming from, like their state of mind. So because if they're 100% not in the state of mind, there's little you can do. So you kind of need to move them along a couple of steps first. So have you thought about quitting? Is always, there's the pre-contemplation phase. If I'm going to get very scientific about this, there's the pre-thinking about quitting phase. And these are the people who are like 100% no, I have never thought about it. I do not want to think about it. I do not want to quit. It's very hard. These people, very hard. You need to get them into the step of like, yeah, maybe I'll quit when I retire. Maybe I'll quit when like this mortgage is closed. You know, these people are considering quitting. If that's it, these people are easier to move into the quitting phase. And so once they're there, I think you should get some help from multiple people in the family, having this discussion a lot of times. And if you have a family doctor, I really do suggest getting help with medications. It really does work. Like I've seen it work with my patients, with my friends, to get help with medications that will stop the craving for smoking. And there's very specific strategies. If this person can reach out to me afterwards, I can send you materials on like the kind of conversations you should have with people who are trying to quit. How to have the conversation and what kind of help there is available. Because like once you get them thinking about smoking, you can start talking about a quit date and a strategy towards a quit date and how to maintain the quitting and all of that. So if you're invested, come up to me and tell me to send you the materials. I will remember. Okay. Good. This one is, can you clarify in details about strategies to say no? I'm just going to go back to this slide. So when you said suggest something else, like what kind of something else do you mean? So suggest doing something else. So if you're like going out with a group of people who are like, let's smoke some joints. I literally don't even know the vocabulary because my teen years weren't here. They were in the Emirates. But if you're out with a bunch of people and they're like, oh, like we're going to so-and-so's place and we're going to do X and Y, like try to suggest an alternative activity. It was very hard in COVID, but I truly think we are starting to come out of it and hopefully there are more options for things to do. So suggest something else. Let's do an escape room. Let's do, that's what I mean by like suggest doing an alternative activity, like filling up your time in an alternative way. Yeah, I don't mean substitute one substance for another. I mean like an entirely different activity, to be clear. If there are more questions that I missed or that anybody wants to ask. I didn't hear you. This is a tough question, Christine. I have a question specifically relating to your presentation. Are you in control? Specifically with regards to the slide about nicotine and shisha. Shisha is huge. I think a lot of the parents will be talking about marijuana, but then will be, forgive me, modeling having like smoking shisha. Is it bad to smoke shisha if it doesn't have nicotine in it? Is there a shisha that doesn't have nicotine in it? Really? It has a lot of tar. Please don't smoke shisha. It has a lot of tar, and like the tar itself has a lot of carcinogenic materials, very, very similar to that in cigarettes. And there was some stat, don't quote me, somewhere that like one session of shisha is the equivalent of like something like 10 or 12 cigarettes, not just in terms of the nicotine content, but also in the rest of the stuff that you're inhaling. Like it's going to your lungs. Just don't do it. Yeah. Oh, I'll repeat. Gladly. After I finish internal medicine, I'm doing gastroenterology actually. The acceptance was last week and we celebrated. It was great. Thank you. So I'm going to be doing gastro, that's colon, liver, and stomach, pancreas, everything abdominal. And then hopefully after that, I want to do hepatology, so that's liver disease. Oh, thank you guys for coming. This was great.